And welcome, and we are really glad you're back.
Thank you for having us back.
Sandra Smith was saying, our general manager was saying that she gets people asking her all the time, where have you been? When are you coming back? So a little bit of break for part of the summer, but
a little bit of a break part of the summer. Unfortunately, we were working for that entire break.
I'm sure.
So I apologize for missing the one. We were under the spotlights of the OR, so my sincere apologies.
Well, staying really busy, I'm sure.
Absolutely.
Very busy. Well, let me introduce you Dr. Kemker, Bernard
Dr. Kemker,
and Morgan Batchelor. You're
Yes.
a physician assistant both at Carolina Orthopedics.
Yes.
And throughout the show, we are going to have their number for you all, which is 252-4430-400. And we will also put up periodically the telephone number because we invite you to call and ask questions.
Absolutely. Please
I
ask
think
questions.
The last time you were on, we had more questions, or at least one of them we've been having, ranging 4+. I mean, we've been really having a lot.
Vince tied me last time with 5 phone-in calls, so please call, because in all honesty, it makes my job easier up here, and please call.
Yes.
Okay, well, you want to introduce Morgan, please?
Sure. So Morgan Batchelor, she is one of my PAs. She started working here at the same time I did, so we were both new to the area, both transplants to Rocky Mount, which everyone thought we were crazy, but Rocky Mount really is a nice place. I mean, it gets a whole bunch of bad stuff that it does not deserve. I mean, there's a lot of really good places and people here. Morgan graduated from ECU.
Yes.
Right, and then South Carolina for undergrad.
Yes, South Carolina.
And what were your focuses in undergrad?
Undergrad, I was an athletic training major, so I did a lot of sports stuff, worked with the football team and a lot of other teams at South Carolina, and then went to ECU for PA school.
Anybody that you worked with on the South Carolina football team that people may know of?
Oh, I'm sure everybody knows Clowney. He was there when I was a freshman, and Marcus Lattimore was there as well.
Yep. So if I ever have sports trivia, I just ask Morgan in the OR, because I don't know. Morgan always knows.
Sometimes.
Sometimes.
Yeah.
But then you went off to ECU.
Yeah, so I went to ECU. The ECU PA program is 27 months. So I finished there in December of 2019, and I started at ECU in February of 2020.
And while you never rotated through Rocky Mount during your ECU training, you were all over Eastern North Carolina.
Yeah, so ECU's primary focus is serving Eastern North Carolina and the rural communities of Eastern North Carolina. So a lot of my rotations were between, we went to Ahoskie, I was in Clinton at one point, did a lot in Greenville, went down to Jacksonville some, even went all the way up into Jackson, North Carolina, or Jefferson, North Carolina, up in the mountains for a week,
West
or for
Jefferson.
6 weeks. Yes, West Jefferson.
Okay.
My grandparents live up there, so I kind of hung out with them for a little bit, did my inpatient hospitalist rotation while I was there, but I rotated through everywhere.
Yep. And how did you pick orthopedics?
So with my background in sports and loving bones and joints, it already knew from the beginning I wanted to do orthopedics, and I mean that was even in high school, so I kind of stuck with it and fell in love with it even more.
Yeah. How did you feel, I'm sure you thought you were going to be doing more sports than what you're doing. Now you're doing like the geriatric sports medicine.
Right, yeah. So I really thought I loved sports, and then my rotation, I did an orthopedic rotation in school, and I worked with a surgeon that did general orthopedics, so he did joints and sports as well. And once I kind of saw both sides, I realized how much I liked seeing the geriatric side of things, seeing the joints, getting everybody back to their normal everyday life. I don't know, it's just different. So I really did enjoy it more.
And we have sports talks probably every day with patients.
All the time, yeah.
When can I get back to golf? When can I get back to pickleball?
Right.
When can I get back to like half-court basketball, tennis? We got a couple bikers and joggers that have had replacements. So we still do a fair amount of sports medicine, just
just a little different.
Just not contact sports.
Right, yeah.
So Morgan has been integral to my success and my office success here in Rocky Mount. Morgan is the person that you'll see before surgery, and you'll see her likely after surgery. You'll see her in my clinic, and I'll let her explain the important parts that she does to make sure you're safe for surgery and that you're prepared for surgery.
So as a PA, the role of a PA in the office before you sometimes even meet Dr. Kemker is we want to make sure that you are safe for surgery. So that involves decreasing all of your risk possible for complications like infections and things like that. So we start that by getting x-rays first to make sure that we're diagnosing you correctly, do all your exam, and then we always get lab work on you.
Correct.
So a lot of labs to make sure that they're where they need to be for Dr. Kemker to say you're safe for surgery.
Correct. I then go over the labs and the x-rays and make sure that, one, a hip or a knee replacement will, of course, benefit you,
Right.
and two, that you are safe for surgery. The other thing that Morgan is excellent at this point is knee injections.
Right, yeah, we do that too.
Dozens of knee injections a day?
Yeah, I think yesterday was maybe 15 in a day.
Yeah, 15 in a day. And to this point, I now have patients requesting her over me for injections, which is wonderful, because she does so many more of them a day than I do at this point.
And what are you treating with the injections?
So treating, what the injection does is it's a very strong anti-inflammatory to help with the inflammation, pain, and swelling, which is what causes a lot of your pain from arthritis.
Arthritis, okay.
We do the standard cortisone shot that you usually hear about. I went to the doctor and got a cortisone shot. We also started doing this new like slow release or long-acting cortisone shot that we've had a couple patients who unfortunately are not able to go on with a hip or a knee replacement that have failed the standard cortisone shots that are getting excellent pain relief for a longer period of time. We also do the gel shots. The gel shots, we get a lot of questions on that because of the TV commercials lately, right, Morgan?
Oh yeah,
Yep.
all the time.
Are
All
you
the time.
doing them too, the gel shots?
We do those
We
too.
do them too.
Insurance is sometimes a barrier to the gel shots, but we do the best we can to try to get them for you if you would like to try them, and of course you're a candidate. The other thing that Morgan does before your surgery is we have partners with local pharmacies around. Would you like to tell us about that?
Yeah, so a lot of, this is more into post-op stuff, but a lot of your pain control after surgery is really important. So we have, I think you've talked about the ERAS protocol afterwards, so a lot of the medicines we prescribe after surgery to control your pains in different ways. So we have a whole piece of paper that we go over at your pre-op appointment that explains what all those medications are and how they work together to control your pain after surgery. We have partnered with Thorns that is in Tarboro. They're the only pharmacy that will make a complete pill pack for us that has all the medications in it that aren't controlled substances, that lines it out based off of your surgery date, so it's specialized to that patient. It has the date on it and it tells you what to take, how to take it, and there's 4 different little packs that you take in one day, and you're on those medicines for 6 weeks. So you get all 6 weeks at one time. So you'll never have to go back and get your refills for those medications.
And having them labeled is huge because when somebody hurts, the last thing they're thinking about is trying to organize, did I take this, did I not take this, and whatnot.
Right.
So that's a real convenience.
And to that point, we also put your blood thinner in there. One of the medications that patients most frequently forget to take is your blood thinner after surgery. And it's a critical one that you have to take after surgery, otherwise you end up with a big blood clot and you read about you in the newspaper. We don't want that.
Right.
So we're just trying to make this as an easy process for you, trying to decrease your pain the whole way through so you can get a good result quickly.
Can we go back to knees for a minute?
Sure.
You have done a great job, Dr. Kemker, with talking about knee replacement surgery. So are the people that you're doing the injections, are they not able to have replacement, or they're not bad enough to have replacement, or what they have going on is not something you would replace it for anyway?
That's a complex question. One, people come in and they have early arthritis, right? And they haven't done a knee injection yet. And we have some patients who come and get a knee injection, they get months and months and months of pain relief. And if it was my knee, and I'm sure Morgan would say the same thing, if I could get months of pain relief and show back up in another 4, 5, 6 months and get another knee injection, that's what I would do, like hands down. I would not take the risk of a knee replacement. I would not want to do the recovery. Once those injections start failing though, that means the arthritis has continued to advance. That's whenever your pain is lasting every day and the injections aren't helping anymore. That's when we decide to go on with a knee replacement. Because again, safety is our number one concern, right? The whole way through we're thinking about safety, safety, safety. Then we think about outcomes, right?
And are some of the things wrong with knees not things that you would ever want to do a replacement on, because that's not an option for what they have?
Sure. I mean, there are things that can happen with a knee that a replacement's not a good idea, like infection or fracture, those kind of things. And we're, of course, checking that with x-rays. Like if you fall or something, we're going to reevaluate you. But most things, once you get over the age of, let's say, 65, for knee pain, even like a meniscus tear or a small chondral injury or flaking off a small piece of cartilage, and the knee is best treated usually with a knee replacement.
Because basically it'll last the rest of their life.
Well, hopefully we're trying. We're trying. I think the technology is getting better and better, but we do try to make it to the point where you hope you only have one surgery. We try to get it right for you the first time.
But that's great. You've got these long-lasting injections and stuff now. That's really great.
That's part of why we like to start off with the injections, because if we can buy somebody's, a year or two at a time, then that's even longer that knee replacement is pushed off a little bit, so that it may last them their whole life. So.
Correct.
Can we get the telephone number on the screen?
I just had a call.
Oh,
okay.
wonderful.
Good. Yay.
But anyway, they want to know, they are scared of the surgery because people say it's so painful to do surgery. What are the options? And I think you just answered some of it if they were watching the injections. But anyway, if you want to address it.
So what are the options? I'll let you take that.
So we kind of go through that in your first appointment when you see us. We talk about how there are medication options. So anti-inflammatory medications are one of the best medicines to take for arthritis pain, because it is inflammation pain. Now, if you're not a candidate for anti-inflammatory, like oral medications because of kidney disease or something else, then we can talk about creams and that kind of stuff. Then from there are the injections we've been talking about. So we talked about the steroid injections, there's gel injections. So those are a lot of the options that we try to exhaust before a surgery.
The one issue we're having right now with gel injections is Morgan or I used to be able to write the exact name brand that we wanted you to get. And right now, to be frankly honest, we're having a hard time getting approval for the exact name brand. So if you come and say, I need blank name brand of this, we can write for it, but we're having a hard time getting insurance approval on that. So we each insurance company has their own preferred brand for obvious reasons. And we go with what the insurance company recommends that we use, so that way it doesn't cost the patient like $1,000 right out of pocket. So that's what we're trying to do with the gel injections and the long-acting steroid injection.
And generally, there's some brand that their insurance would cover.
There's usually...
Yeah, I haven't met one. We haven't had an insurance company say no to all brands at the current moment, but they usually have one brand that they prefer.
Well, to continue the question then, do you want to say, let's say these all quit working. Talk about a knee replacement, please.
So if these all quit working, that's whenever you'll likely be working with Morgan for this, and she'll start getting preoperative labs.
Yep, that's when we get the labs. Then we make sure their x-rays are updated. If they have a pretty significant past medical history, like they see multiple doctors, like heart doctor, primary doctor, lung doctor, kidney doctor, if it's a lot of physicians, I'll at least try to start the clearances then, because a lot of doctors to see before a surgery when the surgeries are, 2-3 months away. Sometimes they get to see him, and they also have to go to an appointment at the hospital too, and we get really crammed on trying to get everything done in time. So.
Trying to get you ready for a hip or a knee replacement takes a lot of work on our end, and sometimes it's very frustrating for the patient. The days of coming to the office, see the doctor, knee replacement are getting pretty difficult for multiple reasons. Again, safety is being the biggest thing. We follow national recommendations. That's why we're doing all this blood work and stuff to try to decrease the risk of infection, of immediate heart attack, of immediate stroke after surgery. We're talking to pharmacies, we're talking to patients about how are you going to control your pain after surgery, and that just takes a little bit more time than just saying, hey, meet you for Friday for your knee replacement, right? But because of that, our results have, I think, shown through locally, and I think our pain after knee replacements, I'm not going to tell you it's pain-free, but the pain after knee replacements is much better than what it used to be even probably 2 years ago. And we're getting scored by all the UNC systems, and I think that would shine through in our scores as well.
Well, and you are so good about planning the program to get them up immediately with, I think last time you were talking about if they don't, scar tissue starts building up and it's hard to ever overcome that.
Correct.
Do you work with them after it all, Morgan?
So they either see me or Vince, the other PA that was on the show before. They see one of us at their first post-op appointment at the office. So 2 weeks after surgery, or 1 week, depending on the patient, you will see one of us after the surgery.
And what do you do during that visit?
So during that visit, it's an incision check mainly. We make sure that they're progressing with physical therapy, check their motion, strength, make sure their pain's controlled, they're taking their medications. That's another one that if they don't, some patients don't get the pill pack, they do get a little confused on their medicine, so we make sure that that's being taken appropriately, take their dressings off, making sure their incision's healing well. send any refills and that kind of thing at that appointment.
And if there's a problem, what happens?
If there's a problem, depending on what it is, of course, the first person that's going to find out is Dr. Kemker.
Me.
So there usually is a text or a phone call if it's really urgent or important. Even if he's in the OR, you know, we're trying to figure out how to get in touch with him because he's the first person that needs to know.
Yep, so even though you'll be seeing one of the PAs after surgery, they are trained to see you. They're trained to make you get to the next step. The next step is usually to see me in the normal post-op visit. I check your range of motion with the knee to make sure that that scar tissue hasn't built in and I don't need to do something. Our rate of that is very low this past year.
It is, yes.
Hopefully that continues on through. And then we continue just to make sure you're getting better as you keep progressing. I would say 90% of our hip and knee replacements, I'd say 99% of our hip and knee replacements are not requesting narcotic pain medicine after their 2-month mark.
Oh, good.
Sure, yeah.
Yeah, so I mean that is a drastic increase or a drastic decrease in the amount of narcotic pain medicine given, and a drastic decrease in patient pain than when I was a resident and a training as a hip and knee specialist. I mean, we used to write for hundreds of narcotic pills, and those things, they make you constipated, they make you loopy. And we actually know that that medicine, that narcotic medicine, the oxycodone, the hydrocodone, actually messes up the pain receptors in your knee replacement forever. So we actually
Forever?
Forever. Yep, it'll fry the pain receptors in those knees.
Wow, I'm
So
glad that's been discovered so you can really steer away from them.
We try to do all these other medications and pain protocols to decrease your pain without
There
the
was
use
a
of those.
call, did you know? Have you got,
Yeah, they want to
Number
know
2
how old
already.
is too old to have knee surgery.
What's our oldest patient so far?
I think elective joint replacement is in their 90s.
Yeah, I think our oldest knee replacement is 99. Just signed up an 88-year-old. Elective hip replacement, I think we've got a couple 93-year-olds that have come through. I mean,
And I tell patients it's not age. You know, I've seen patients that are in their 90s that are healthier than some of my patients in their 50s. I mean, it's not just about age. There's a lot of factors that go into it, and a lot of it is about your past medical history. I've got some 80, 90-year-olds that are on blood pressure medicine and cholesterol medicine, and I'm like, hey, you're pretty healthy. So.
and do they do well?
Oh, they do great.
They do great.
They do awesome.
That's actually who the knee and the hip replacement was designed for.
Yeah.
The patients that were really pushing the boundaries with hip and knee replacements are the people under the age of like 55. We'll do it, but that's whenever we know you're going to have another surgery, if not 2 in your lifetime, right? And the recovery is a little bit harder, especially on the knee side if you're younger, because you get so much more muscles in that leg. And it just hurts more. I'm not going to make any joking bones about that. And that's why we, again, offer all these non-operative things to you as well.
but if the person is a senior who's calling, for instance, and it is generally if people need a hip replacement or a knee, they're in a lot of pain.
Horrible pain.
And this can really improve their quality of life, can it?
It is a
yeah.
quality of life. My patients that are over the age of 85 are our happiest patients. I mean, it's another level up from how most people recover from a hip or knee replacement. One, I think these patients of that age, they know what pain is. They've been alive for 90 years, right? They've had more instances of pain than I have, for sure. And they just accept life a little bit more, and they're willing to get back some of their quality of life.
And their mobility.
Mobility and independence is the other one.
Their independence is almost more than younger patients.
If you can take someone who is like trying to lose your job because of your hip or your knee arthritis, that's pretty common.
Yeah.
Especially with the industries around here that employ a lot of people, right? It's tough labor, and it will wear stuff out quickly. Getting you back to work is wonderful, right? Keeps the house over your head. However, if your hip or knee arthritis is getting ready to get you kicked out of your house that you love so much to go to a nursing home, and we can keep you in your house, people like that even more.
That's huge.
It's huge.
Yeah. Well, we need to take a quick break. When we come back, I hear that you do the best stitches, the most beautiful stitches of anybody in this whole area.
That's what they say.
Gosh, I want to talk about that a little bit when we come back, but we'll be right back. Stay with us. And think about questions, too.
experience was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. So any surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
If you want fine dining that goes beyond just eating, come to Lily Ann Steakhouse. It's an experience. Exceptional food prepared by our famous chef, meticulous service, and upscale ambiance. Certified Angus beef, choice and prime, seafood, pork, and chicken, all seasoned to perfection. Book your private function with us, birthday parties, or any special occasion, or even meetings for your company or civic group. Lily Ann Steakhouse, located at 139 Gateway Boulevard, open Monday to Thursday 4 to 10, and Friday and Saturday 4 to 11.
We're back with Morgan Batchelor, physician assistant, and Dr. Bernard Kemker, Carolina Orthopedics, and the number for your questions, 252-407-1111. Please feel free to call. We love your questions. During the break, well, let's talk about first your stitching. Our general manager was just saying that you sewed up her son-in-law, and it was just absolutely fantastic. And the PAs do a lot of the sewing, and I hear they do a better job than the doctors. Is that?
That is absolutely true. Morgan has been closing for me for what, 5 years now?
Yep.
I mean, at first, when we were first in town, we made sure that everything was looking pretty and making sure we were getting our routine down well.
Yeah.
How many people come up and show you their near invisible incision?
Oh, I mean, a ton. Even Kemker will pull me out of the clinic. He's like, hey, I've got a patient that wants to show you their pretty scar. Like, they
Yep.
love their incision. And I even had a patient the other day that we did surgery on one of their friends, and she's like, we're going home now, and we're going to compare our scars and see who's got the prettiest scar.
Yep.
So.
Yep. Morgan was on vacation one week, and I did not have her in the OR, and she closed one lady's knee, the one side, but I had to close the other side. And I got a bit of a talking to that how dare I do her surgery with Morgan not in town because her other scar looked so pretty. My scar turned out looking just fine, but you know, everyone has been very happy with the way our incisions look.
Well, and I want to talk about a physician assistant. Mm-hmm. You are not an assistant to Dr. Kemker. You
No.
have medical experience in your own right, don't you?
Right. Yep. We're a completely different. You don't. A lot of people think that you choose or you do the physician assistant to then go to medical school and be a doctor. I have a ton of patients that still ask me to this day, well, are you going to go on and be a doctor? Like, are you going to keep going? And you kind of choose if you want to be a doctor and go to medical school or if you want to be a physician assistant. Mm-hmm. So we can practice on our own, see our own patients. We do have supervising physicians as well that oversee us and, you know, read all of our stuff, and they're there for advice and help us and guide us as well. Mm-hmm. But we can see our own patients. We can do our own injections and procedures in the office. Of course, we have a scope of practice like everybody else does. Mm-hmm. But
you mean the scope of practice, things you're allowed to do?
Right, like I can't go and do a surgery. Okay. You know.
Right. But I also can't go and do a central line.
Yeah.
Mm-hmm. Right. Every hospital, you have your own credentials. So Morgan is her own individual health professional, mm-hmm. right? Mm-hmm. So it's just a different title, and the responsibility is a little bit different, but the care is not.
Right. Yeah.
Well, the way they complement each other, the physician assistants. I was looking at your staff at Carolina. Is it regional orthopedics or just mm-hmm. Carolina Orthopedics? It's got regional.
Yep.
Okay. I was looking at the staff. You really have quite a few PAs,
Correct.
and they're extremely helpful.
They're extremely helpful. If I didn't have my PAs, the wait line to see either Mark Perlmutter or myself or any of our other employed surgeons
McNichol and
would be months.
Yeah.
I mean,
Okay.
it would be months and months and months and months and months. So that means months to get a cortisone shot in your knee. Right? Like that means I'm getting ready to go on a trip, I'm getting ready to go on a cruise. I need something for my knee or my hip or my back or my shoulder, right? I need something. And Kemker is booked out for months. With having the PAs being their own independent practitioners, we get people in evaluated and treated, like frequently. And we do that on purpose to help the community, right? We're trying to get people in because they hurt. We're trying to have it not wait months and months and months to see someone.
Right.
I know I called, my husband needed a steroid injection, and I think it was the next week I called on a Thursday, and Nick and Vince could see him yesterday, and that was wonderful because, like you said, people, when they're hurting, they don't want to wait
You don't want to wait.
a really long time.
And especially if you got like a wedding that you're going to, like your first grandbaby's wedding, right? You want to, and you want to go dancing. I mean, that's probably that in a cruise. Our number 1 and
Vacation in
2
general.
vacation, or our
Yeah.
1, 2, and 3, like get me in, I need an injection before I go. And,
Yeah.
and with the additional physician assistants in our office, we can oblige that within a couple of weeks instead of a couple of months.
Right.
So do you help much with the rehab after the surgery?
So that's to our physical therapy department, which we do have a physical therapy department in our office. I do prescribe their physical therapy after surgery. It is very important to have that set up. So that is one thing we talk about at their pre-op appointment, and the hospital helps me with that as well. But there for a while, I think it's getting better in the area, but it was very overbooked in the area, and there was a big shortage. So I make it when you see Dr. Kemker get your surgery set up, we go ahead and send the referral off to physical therapy, so you can go ahead and get it set up, because we want you started 2 days after your surgery. So we don't want that time to come the day of surgery and you're like, wait, I don't have my therapy set up yet, and then we call your physical therapy place and they say, hey, we're booked out for
Correct.
3 weeks, 4 weeks, and we can't get you in. So we always make sure that your therapy is set up when you see me for your pre-op, which is within 30 days of your surgery.
And what you'd say that takes hours of additional time when you're not face-to-face with the patient,
Oh yeah.
right? And how many of our patients would say things went smoothly and without a hiccup because of how much planning and work y'all did with me?
From what we've heard, our patients are the most informed and educated out of all the patients that get joint replacements
And I
in the
would
area.
say
Good.
Yeah.
95% of our patients, we try to make it 100, that's kind of an impossible goal, but I would say 95% of our patients say, that went as you told me it would, almost to like the day and to the minute. We are extremely thorough, and Morgan spends a ton of time with the patients
Yeah.
to really make sure they know the plan.
We have a question.
Absolutely.
Oh, good.
This lady says that the front of her knee does not hurt. She said, I have a bone that I feel on the side of my knee that is hurting now when I walk some. Not all the time, she said. She said, what is that?
So kind of hard depending on the side of the knee, but knee arthritis most commonly is on the inside of the knee. So it's actually more common for patients to hurt on the inside of their knee, not the front of their knee for arthritis. So they can usually take a finger and point to the inside of their knee and say, this is where my knee hurts.
Not-
There's a bone on the side of her knee.
So what it can happen
Yeah.
is when your arthritis gets so severe, I'm sure people have heard that your knees get bow-legged or knock-kneed,
Or
right?
big bone spurs.
Or big bone spurs.
yeah.
So it could be one of those things that when your knee gets so bow-legged, it looks like it's an extra bone because it's so deformed, or you could have a bone spur from the arthritis
Yep.
being so severe.
And
I
it'll,
believe she's listening.
yep, and that'll feel, it hurts.
Oh, it hurts.
I mean, I've only been punched by one person in my whole medical career, and it was a sweet little 80-year-old, and I touched the bone spur too hard when I was a medical student, and she got me good. I mean, that stuff hurts. It hurts
Yeah.
really bad.
Yep.
Oh.
Yeah,
So what do you
that's it.
recommend for her?
Come see us.
Yeah.
Come see us. That's kind of one of those first appointment things where we sit down and talk to her about all of her options after we get her x-rays and
Yeah.
do her exam.
That does sound painful. I would, and also, anytime something's different, I want to know what it is. I don't just leave different things happening because
Right.
we know our bodies. I mean, we take care of ourselves. We know what we feel like, what's
Right.
normal for us. And if something's not normal, it's a good idea to get it checked out.
Right, and I mean, just coming in and getting the peace of mind of an x-ray and make sure that something isn't broken or something rare isn't happening, right? Just get you peace of mind whenever you go to sleep, like, oh, it's just my arthritis pain. Again, I can go to sleep. It's not some crazy thing, or everyone thinks it's a tumor, right?
Yeah,
It's
the
not some
scary
crazy
stuff.
thing, yeah.
Yeah.
So come and see us.
But as people get older, it's not unusual to have stick-out places and bony places and
No.
have your body shift a little bit here and there. But
No.
it's good to know what's going on.
Right, right.
That was an excellent question.
Yeah.
It is. I want to talk about hips, because I think I know a neighbor of mine recently had you do hip replacement surgery, and he said it was absolutely wonderful. And I said, why did you go to Kemker? I just think he's great, and I've heard about his anterior procedure with very minimal muscle cutting and whatnot. And he said, that's why I went. I learned that he could do minimally invasive, and I said, you talk about that's
not
the
big.
size of the incision.
Especially when Morgan's done, she shrinks your incision even smaller.
Oh, good for you,
Makes
Morgan.
look better.
But that, in case people didn't miss that program, tell them about that, please.
Sure. So one of my specialties is with the hip replacements is hip redos and the anterior hip replacement. The anterior hip replacement, you don't cut the muscles, so you try very, very hard to not cause any muscular damage. The reason being is cutting muscle, number one, hurts. When you hurt, it slows down your recovery. So this speeds up your recovery by a couple of months, to be honest. There's a less chance of the ball coming out of the socket called a dislocation. Those are the three main reasons why I do it. Additionally, I think I do a better job from the front. We can use x-ray. That helps us use some additional technology, so we make sure the parts and pieces are in the right spot. Try to get your leg lengths as close as possible, so that way you're not walking with a limp. The other approaches, other than the anterior hip replacement, will take you longer to heal, have a slightly higher risk of a dislocation, and several of the older ones even have a much higher chance of walking with a limp. We do have patients that still walk with a bit of a limp after surgery, but they came to us with a massive limp.
Oh.
I mean, one of the most common questions we get after a hip replacement is, am I going to need a cane anymore?
Oh.
Am I going to walk with a limp? Right?
Yeah.
There's things that we cannot change. Number one, the cane. I like canes. I tell patients, hey, if you think you need a cane, that's not a sign of a failure. Morgan and I don't want to see you with a broken hip when you fall in the ER.
Right.
Right?
Yeah.
So if you need a cane for some balance, please use it. A limp has multiple things to do. If your hip's been so bad for so long, it'll start affecting the muscles and your balance for the rest of your life. So if your hip is starting to hurt you, please get it checked out by someone.
The sooner the better.
The sooner the better, yep. And we may not push a surgery on you. We are pretty slow to push a surgery, to be honest. We might try some injections. We have people that get injection every 3 months, every 6 months, every year. So don't think you're coming in to get cut on right away. We try to actually avoid that.
But if it's going to mean that somebody's going to limp the rest of their lives because they screw up their muscles.
Yep.
I mean, I had a friend who had hip replacement surgery, and she refused the physical therapy, and she limped horribly the rest of her life.
Correct. Yeah, you got to do the therapy. You got to get those muscles strong. I mean, our happiest patients are 90-plus-year-old hip replacement patients, and it's not even close. I mean, these patients have been putting off a hip replacement at that point probably since they've been 75.
Hurting that long?
Yeah.
Oh, gosh.
Yeah.
Well, that's one of the things I like about this program. I mean, if there are people who are at home who are suffering and don't realize that there are great ways to make it better, whether it's injections or a hip replacement surgery that could really, is not that bad anymore.
Yep, and
Right.
we'll talk about other stuff like holistic medications like turmeric and that kind of stuff. We'll recommend the why. Like, we're very open to work with what you want to do as long as it makes sense to your hip. Now, if you come in and your hip is like really probably needs to get replaced, Morgan and I are going to say, time to pull the plug. Like, we probably need to start working you up for this. We'll try the other stuff if you want to, but probably not going to work so great.
Is there ever a case where you are not able to do hip replacement surgery from the front, the anterior?
Yeah, we've been pushing it more and more, wouldn't you say?
Yeah, I mean, most of the ones that you can't do from the front, there's usually a previous surgery involved or
Yeah.
previous injury involved or something.
Yeah, that's true. I mean, for the ones that we typically aren't doing from the front are like if they had a hip, if we're redoing their hip, and it's already been done from the back.
Or they had other hardware in their hip,
Yeah.
like a fracture or
Yeah.
something else.
If we got to remove something, it would be the biggest reason to not do it from the
Yeah.
front, because if it's in the back side of the hip, then you're going to it will no longer be minimally invasive. You have to go to the back side of the hip.
Last time you were on, you talked about how much you like UNC Health Nash, that their OR there and the support staff and whatnot was really good. For people who didn't hear that, how about, Morgan, you go there and assist in
Yeah.
operations. Talk to us about our hospital, how.
So he's been working with them about developing the program to get all our patients up and moving, but the OR staff is great. I mean, I hear nothing but great things from our patients. They make sure that the nurses take a great care of them. They're there, you know, call bell in reach, always making sure our patients get the medicines that they need, helping with their pain. They do get them up very early, which our patients aren't thrilled about, but that is part of the program. But the staff is great to deal with. We usually work with the same people pretty consistently, so we all know everybody's flow and get along really well. So.
Correct. And the OR staff and the physical therapy staff, the joint replacement staff, to be honest anymore, they don't call me for a question. They call Morgan.
They do.
Because I'm usually lost somewhere trying to make someone who's very sick better. The program over there is good, and you mentioned the early wake-up time.
Yep.
We have early wake-up time. How many patients complain about the early wake-up time once they see why we did it?
Well, once they see why they did it, why we do it, they don't complain that much, but they also get a forewarning from me in pre-op. I say, listen, this is a little, we joke around saying it's a joint replacement boot camp, but it really is, because that's part of getting up, getting out of bed, getting in the chair, getting you ready for the day, so that when you go home, you're like, oh wait, I've never done this before. Like, I don't know how to lift my leg out of the bed. I don't know how to put my clothes on because my knee hurts so bad, you know, and that's stuff that they work with you when you're in the hospital so that you're prepared when you go home.
And does the staff at the hospital work with them, or do you come in and work with them?
The nurses at the hospital and the physical therapist and the nurse aide are usually the ones that help them kind of do all that while they're at the hospital.
Yep. Morgan and I typically come around and we know that something is not right on one of our patients whenever we walk into the room, and this is for first-time knee replacements, first-time hip replacements, hip redos, and knee redos. If you're not sitting into that chair, it's kind of a red light to Morgan and I, like, okay, something is not right here. We have to fix something.
Yeah, like what happened overnight for our patient not to be able to get out of the bed and sit in the chair first thing in the morning.
Oh yeah,
Yeah.
because that makes all the difference in their being on a trajectory to get better as fast as possible.
It makes all the difference.
Ask him before we ask this question. Let's go to break.
And,
Go to break.
And
Okay.
the other thing that Morgan is extremely good at is at your appointment before surgery, I'm going to tell you the plan. The anesthesia program is going to tell you the plan. Morgan's going to go over the plan with you in fine detail. And all the patients, they appreciate it so much, because you don't know what's on the other side of a surgery until you're there, right?
Right.
So we do such a good job, Morgan does such a good job at making sure that you know what's going to happen to your hip or your knee, what to expect, and we give you emergency protocols to follow as well. So that way you don't ever feel like you're alone somewhere where you don't want to be.
And it's always nice to have a family member with them.
Oh, 100%.
course.
Too.
Yes.
I'm all into telling people, if you go to the doctor and it's something serious, take a medical advocate, take a family member, because for two people to hear it is much better than just, because the patient hurts or the patient might be on medication, and it's great that you repeat it, but it's always nice to have a family member that you know
absolutely.
you can make responsible too.
We make the family member sign a contract at the hospital.
Yep, that's another part we do too.
Okay, let's take a break and we will be right back. Stay with us.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough, and I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
When When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
What is Celebrate Recovery? It's a Christ-centered, faith-based recovery program for anyone dealing with life's hurts, habits, and hang-ups. Celebrate Recovery meets every Thursday night at 7 p.m. at Farmington Heights Church in the Wilson, Raleigh, and surrounding areas. Please join us every Thursday night at 7 p.m.
And the question that Sandra was telling us that somebody called in, and we appreciate your calls, number 407-1111, involved a person who'd had knee replacement surgery, and the physician who did it was out of town, who is and she is choosing to stay local, which we really like. And I can't, anytime anybody has something done, it's awfully nice to have somebody really good locally.
Correct.
So all your follow-ups and everything are right here.
Correct.
Yep. And folks, we do have excellent people who can do it locally, but she asked about a zip closure.
A zip tie closure.
You want
is what
to
she
address
said,
that,
yeah.
Morgan?
So we don't do the zip tie closure, but we do the suturing that we use is dissolvable. So it is underneath the skin. It is dissolvable. It's a very fine suture. It almost looks like a fishing line, but it's so small that we can run it right under the skin. It dissolves usually around like the 2-week mark, but you have skin glue over top. So there's no stitches to take out when you come into your 2-week follow-up with us. And we use a special dressing. Actually, this is what patients love, is they can go home and they can shower. So it's water resistant. So you can't soak it underwater, like you can't get in the bathtub, but you can shower, let the soap and water run over it, and pat it dry.
Right away?
So, right away. So that's one thing that our patients absolutely love, to be able to shower when they go home.
Oh, yeah.
And we want you to shower when you go home as long as that dressing stays on. Now, say you have really thin skin, what do we do then?
So if you have really thin skin, we use a different type of suture called Proline, which does have to come out at 2 weeks, but we use a special type of dressing over top of that called a Pico dressing. A Pico dressing is a negative pressure therapy, which is, I know everybody's heard of wound vacs before, so it's similar to a wound vac, but it's not as strong of a suction. But what that dressing, the Pico dressing allows is it allows any type of bleeding, which thin skin usually does bleed a little bit more, so it allows that bleeding to get soaked into the dressing. It stores it in the dressing, and the suction allows new blood vessels to form over the incision, so it helps promote healing after surgery. We bring those patients in at a week. We change that dressing so you have a nice clean dressing, and the batteries last for 14 days in that wound vac or the Pico dressing, so it still stitches come out at 2 weeks.
Yep. And the reason we use the Proline is because I take the stitches out the vast majority of the time. 50%, would you say?
Probably, yeah.
Yep. When the stitches for the Proline come out, they come out nice. They come out much easier than other ones, and I'll be honest, they leave as pretty of an incision as do the straight down with the invisible stitches that we use. And again, we're trying to give you a cosmetic effect, so much so that whenever Morgan and I do redos, we cut the old incision out and throw it away, right? And a lot of people really like the new closure that Morgan gives them at the end, because it's usually a much finer closure, especially if you got a wide scar.
Yeah, I've seen wide scars on knees before, and that's why when you said, well, Morgan doesn't do that, Morgan's scars are beautiful if you can even see them.
And a lot of the patients that have those wide scars, they come to me afterward and they say, well, I had staples before. Like, why don't we do that anymore? Staples leave terrible scars. So.
Staples don't leave great scars.
And they're not fun to take out at all.
Nope, they hurt.
Yeah.
And possible increased risk of infection with staples. I think we've had to staple a couple of patients for very specific reasons, and we very much try not to.
Yeah.
So the majority of your hip and knee people are over 60, would you say, that you do surgery on?
For the knees, for sure. Hips are a little bit different.
Yeah.
I mean, hips, there's so many different things a hip replacement can treat, not necessarily arthritis. So like if you had a bad accident when you were little and the hip just healed wrong, or if you have a pediatric condition where the bones weren't formed right, that's more common in the hip than in the knee. And the answer there is usually a hip replacement at that point because you've usually worn out the cartilage. Or some people I'm sure are listening have heard of avascular necrosis, which is like a heart attack to the hip, and the hip kind of dies in on itself a little bit, and that's treated with a hip replacement. So our youngest hip replacement has been, we haven't 20 years? 20 years old, 21, 22?
Yeah, very,
I haven't done anyone under 20 yet here.
I don't think so.
It's coming. So the hips are a little bit, hips are 18 to 100. Knees are usually 55, a couple below there and up.
Well, and I know you're the only one in Rocky Mount who does the anterior hip.
Routinely, correct.
You had to go and really train, especially to know how to do that, though, didn't you? I mean, that wasn't part of your training when you came through?
We did some anterior hips in my residency, and then in my fellowship, I continued with the anterior hip training to make it, you know, more muscle-friendly, less invasive. And then after that, I took it the step further to do the bikini incision. The traditional anterior hip incision goes straight up and down on the leg on the side, like where your front pocket is, in about, what, 2 years? It's been 2-3 years now?
I think so, yeah.
Something 2-3 years. It was Mother's Day. I went and learned how to do the bikini incision, which is kind of a diagonal incision across your leg. And I mean, that thing heals up so well.
So much better.
I mean, there's people that have that incision on that it looks like a wrinkle from their underwear. Hence the name bikini incision.
Yeah.
So if you're looking to get back to the Outer Banks and are worried about a big scar, let us put a bikini incision.
Well, now it's time of year, too.
Yeah,
I mean,
now it's time of year.
Yeah, getting past bathing suit, and by next year, you'll be better than new.
One of the problems with the traditional anterior hip incision, that straight up and down incision, it has its pluses, and we'll still use that whenever we need to, is that that one actually heals pretty wide. So we really switched to one that has less wound complications, and it for sure has done that for us, and it heals so pretty.
And the skin like just falls right back together. So.
Another thing I've been telling people, I learned stuff at these two folks. I'm just like you. I'm sitting here just drinking all this in. I was telling someone about the 3D knee cup, because so many people have had knee surgery and the knee just goes up and back, right, front and back. And now down there starting to do the or the 3D printing of a knee so people can have more if they play tennis or something, or pickleball.
Sure, so we switched to a new knee that is supposed to be a higher performance knee model. And I would say so far our patients' range of motion stuff after surgery has been like better, like not even like a little bit better, like better.
So you're already using it?
Oh yeah, we're already using it. The knee is just often thought of as a hinge that goes back and forth, back and forth. And the old knee replacements, that's what it was designed to do. And that's what we could make at the time. We didn't have the mechanical engineering, we didn't have the factories that could make this stuff. As technology has advanced, we know that the knee just doesn't swing back and forth. It also pivots. Like you can take your foot and you can watch your knee pivot if you look down at it. And whenever it swings back and forth, it's supposed to pivot. Then you add the kneecap on top of that, and it's actually moving all over the place. So this newer knee replacement we're doing is trying to control and make your knee function like a more normal knee even before the knee replacement. No knee replacement's ever as good as your 18-year-old knee. That's what we're trying to do. And I'd say so far it's definitely been a better process for our patients.
So about how many have you done like that?
Oh, you got me on the spot.
Ballpark.
We did 200 hips, 200 knees last year, and just shy of 100 hip and knee redos.
But we started every year.
Yeah, but we started over a year ago. So
like
we're probably about 200 knees in and probably about 200 hips in. I'd have to go sit down. I don't want to over-exaggerate on
Do
TV.
most of the knees now ask for that ability, not just the straight hinge, or?
Not really.
No, that's just our standard kind of.
Oh, it's standard.
Yeah, that's our standard knee replacement now.
Okay. Yeah. Okay.
Unless you need a knee replacement that's got a little extra beefed up features on it for one of those other things I was talking about, bone deformity, previous fracture, that kind of stuff.
I would think for balance, having more flexibility in the knee would be better too. And of course, falling down is really a danger as people get older.
So one of the things knee replacements don't do well at traditionally is uneven ground. And what do people like to do in Eastern North Carolina? Go to the beach. Go to the beach. So knee replacements, walking on the beach was always something that was kind of difficult for our patients, right? So far, we've had, I would say, less complaints about walking on the beach. People have really liked that bikini incision on the beach for the people that still wear, you know, a traditional bathing suit. Most people over the age of 75, not so much.
Not so much.
But, you know, some people do.
Maybe somebody would like to call in and talk about their, you know, 80-year-old body with a bikini.
Sure.
And whatever,
Sure.
So.
But yeah, that's how we do it. We're not using a robot yet. We are looking into one to see if that's something I want to do, see if it's something that the community needs. So
For what? Surgery?
For surgery, yeah. The robots aren't any more or less invasive. In fact, I would actually say they're more invasive. I'd have to make my incision bigger to fit the robot in there. It just really helps you put the parts and pieces in a better spot. So far, we're not having that problem.
So would the hospital purchase that equipment, or your practice would have to hear?
It's usually an agreement with the hospital and the implant companies. It's one of the things we're looking into, but I'm still very much on the fence about it. It's not improved.
Well, and with your skill set, I like knowing that you are looking at it and right there doing it yourself instead of with the screen trying to do it with a robot.
Well, correct. If there was something that came out that said this is the way to do it, we would switch immediately, right?
Yeah.
Like if there's some new technology came out and said your complication rate goes from 1% to 0.1%, I'd buy it tomorrow. I mean, there would be no second. But there's nothing that has come out yet that has decreased the complication rate or increased patient satisfaction other than good preoperative planning, optimization, right, making sure you're healthy enough for the surgery, and making sure the patient is ready for surgery. Those three things, a good plan, a safe plan, and a healthy patient, as healthy as we can make you, are the three biggest things to drive success. And that has been borne over in any academic center time and time again.
And that's why your success rate with not having complications is just you're tremendously.
Yep, we try to keep our complication rate around 1%.
1%. I mean, that would be unavoidable. You know, that was a none.
Right.
I would love to have none.
Morgan, do you work just with Dr. Kemker, or do you work with any of the other physicians?
I mean, technically, they're all my supervising physicians, but I only work with him as far as the patients I see.
And do you have, now you've got 2 PAs who primarily work with you, Dr.
Primarily, yeah. And originally the plan was to have Morgan work with the other providers as well. She just got so busy by herself with patients liking her and wanting to come back and see her that.
Between that and our surgery load has gone up so much, I mean, there's not enough time in the day to see everybody else. So.
Well, I hope that that you see more. Right now you're doing more hips, but knees, I'm sure there's a lot of knee damage and whatnot. So you've got
a lot of knees.
Locally, we could pick up a lot of business with knees, couldn't we?
I think so. I think a knee replacement, everybody wants a knee replacement that doesn't hurt. I would love to tell you I could do that. I would say it is very rare for me to have a patient coming in at the 6-week to 2-month mark that's really hurting, or have seen Morgan that's really hurting. Again, 90% of our patients don't need additional narcotics after surgery, after that 2-month mark, unless you're already on it before from like back pain or something like that. That's a different thing altogether.
Yeah.
But we get pretty good results in the community. We have people coming in saying, you did so-and-so's knee, and I saw him at the bank 2 days after his surgery, and that waterproof dressing that Morgan put on him, and he was just off going. It's like, well, yeah, you know, we just don't do hips. We do a lot of really good knee things too.
Yeah.
Yeah, I like the ability to move more than just a hinge too.
Yeah.
I think that's do you hear of anything with AI coming down the pike that you would be incorporating?
Yes,
Yeah.
that's kind of the robot thing I was looking at is augmented reality. AI is going to change a lot of things. I don't see it like in the clinical side yet.
No, not so much.
Not so much, but the robot or the newer technology I'm looking at just takes and gives you extra data, gives you an extra set of markers to try to make sure that you're doing this to like a 0.1 degree, right? How much does that matter for the patient? If it bore out that it was a 0.1% risk of any complications, I'd do it tomorrow. But I'm looking actually right at the augmented reality stuff.
Well, you have to have a certain number of CE points annually, don't you? And you go to conventions where people are sharing new information and bring it back here. So I really like that you've learned that when people use narcotics that it impacts the muscle, and so that's a really strong reason to stop doing that.
It'll impact the pain receptors around your knee. What Morgan will say is this stuff's going to fry your knee if you keep using it. We're not trying to hurt you. We just got to try to get you onto something else to make you feel better. One of the best things for knee pain is ice, and we sell the ice bucket at the office, the ice machine at the office, to keep circulating the cold ice around your knee. Unfortunately, somebody made a study and that showed no difference with just an ice bag.
Oh.
The problem is people don't have industrial-sized freezers or industrial-sized ice makers at their house to keep a big old bag of ice on their knee. So that's one thing that we're kind of having to fight with frequently to try to help you out with pain. And we'll help you out with Amazon or our office. We'll do everything we can to try to get you through this as less painful as possible.
And you mentioned physical therapy. Sometimes they use the hospital physical therapists, but you have some that work in your practice too, right?
Yeah. So we have a physical therapist whole big department at our office. There's 2 physical therapists, and they have assistants that work as well. So we have a lot of our patients that like to come to us. The benefit of that is you're right down the hallway. So if you have a complication, or say your dressing's falling off, instead of having to bring you in for a whole separate appointment, and you have to drive from one place to another, we can just run down there and see you, switch it for you, make sure everything's going okay. So that's the really good benefit of having physical therapy right there.
And urgent care, I think some people also don't realize that they can come to your office if there's something urgent. Dr. Kemker, you want to talk about that?
I'm probably not the best person to talk about it because I don't have urgent care appointments.
All
the PAs have urgent care appointments. I don't have slots in my schedule for it at the current moment. So
yeah, so all the PAs in the office have urgent care visits or appointment slots worked into their schedule. So we have a certain amount. I think there's like 2 in the morning, 2 in the afternoon for every PA in the office. So it depends on how many PAs are there. So sometimes there's 3 PAs.
So you're on call, or are you in a certain location?
No, we're working in our same regular scheduled clinic, but we just have certain appointment slots that are open and available for patients that call in or walk in and say, hey, I just fell and hurt my wrist, or I just, walking up the stairs, felt a pop in my knee, and it's been extreme pain, since that. And they just work them into the schedule, and we see them that day.
Yep. So that way you don't have to wait in the ER. You don't get the ER charge.
Yeah.
You're in the specialist office already, right? So Morgan will go through, get your x-rays.
Yep,
And
we get x-rays, do the physical exam, and talk about your options from there. Injections, medicines, if further testing's needed, we can take care of all of it.
And
if it's a fracture,
if it's something that needs surgery, they'll be calling me or Dr. Perlmutter on the phone, and we'll be trying to figure out how to get you to your treatment as quickly as possible, instead of go to the ER, wait a week to see us, and then wait another week, right? So the urgent care actually accelerates your care.
And often the emergency room, or ED as they call it, is just really busy. And you can wait a long time there.
Many
and if you know it's an orthopedic issue, then to go straight to your office.
Correct. And again, there are things that you have to go to the ER for, like if you broke your hip, like you got to go to the ER for that. The ER is great at many, many things. However, there are things that even an ER doctor will tell you that that shouldn't really come to the ER. And those are things like small ankle fractures, wrist fractures, some shoulder fractures, arthritis, swollen joints, like all that stuff. You're best coming to an urgent care.
And there's some things that aren't appropriate for urgent care too, like you said, hip fractures. I mean, there's some things that we can't image at an orthopedic office. We don't have CT scans and stuff like that. So if there is any concern about that, then unfortunately we'll have to say you do need to go to the hospital.
I would say 90% of musculoskeletal stuff should come through an urgent care.
Yeah.
Well, I hope if anybody at home has been putting off something, or you hurt, as we learn, the sooner gets checked, there's less damage. The healing, or your quality of life, how you walk, whatnot, is so much better if you can get it addressed on the early side. So we don't want you to hurt. That's one reason we're doing this show, is we want to bring medicine to local doctors and local healthcare professionals right into your room, so you can listen to them and learn from them. So
correct. And to that point, there is preservation things that we do to try to not let you go on to arthritis, to not get arthritis at such a younger age. And some of them are surgical. We offer them here. Some of them we have connections that we could get you into quickly, so that way you aren't disabled and debilitated at the age of 30 or 40. So if you really are hurting, there's no reason to keep thinking about, don't think you're silly if we get an x-ray and we don't see anything. We believe you when you're hurt. We have no reason to. We're more than happy to look.
Okay. Yeah. Morgan, I'm glad you came.
Yeah, I appreciate it.
We've been hearing about the wonderful Morgan who can do the
Yeah,
best.
finally got to make it.
Best surgery or the best incisions possible. So good. Nice to meet you. And
Yes.
Dr. Kemker, we'll see you again in a few weeks, hopefully.
Hopefully.
Okay, great. And we look forward to having you join us too. Have a great evening.